Hello. We are addressing the knee under the bare bones section. The scope of this module is to focus on the facts that I feel one needs to know when addressing imaging of the knee. And although you will see a lot of MR images, the emphasis here is to note the pathology that we need to be aware of, whether it's imaged by plain film, CT or MR. MR, of course, is very sensitive and is a very, very good tool for assessing disorders of the knee. There's a good rule in musculoskeletal radiology, which is this, that if you don't look at the soft tissues at the beginning of your assessment, you are unlikely to do so at the end. So kindly, always look at the soft tissues before you address the bones and the joints. With regard to the knee, the first duty that we have is to see whether there is evidence of an effusion, which is a collection of fluid within the joint. And if there is, we need to think about what fluid type it could be, and if there is associated synovitis producing the fluid within the knee joint. In a lipohemartrosis, what we are talking about is that there is presence of blood within the joint as well as a fatty component. And by this we mean that the marrow has released the fatty component along with the blood. So if one sees evidence of an effusion with a fat layer above the blood layer, one can be absolutely sure that there has been an injury to the intra-articular components of bone. And it is this that alerts us to look even more closely to allow us to detect a fracture that can easily be missed involving the epiphysis of the medial femoral condyle. The lipohemartrosis can also manifest itself, of course, with modern imaging, whether it's CT or MR, except kindly remember that with MR, not only do you spot the fluid level indicating the hemartrosis, but there would be another level above that, depending on what sequence you choose, to identify the fatty layer above it. With regard to synovitis, whether you use ultrasound or MR, the presence of thickened synovium, usually nodular, can be diffuse, as in this case, or more regional. One can identify the presence of solid material highlighted by the presence of fluid by the various sequences that you use. They can assume a more florid pattern in the so-called lipoma arborescens pattern, which is a subsynovial process which has these frond-like, finger-like defects surrounded by fluid that's produced by the lesion. Another important evidence of synovial disease is the space occupation, as well as the fact that it's solid, but more importantly, the MR signal characteristics. So one can differentiate the fluid component from the solid component, which particularly on T2 or PD fat set sequences has very low signal and foci of hemosiderin within it, as the disease is pigmented villonodular synovitis. Here's the patient showing extension of the disease in the intercondylar notch and also superiorly. More often than not, these patients have a lot of fluid. It can be nodular or it can be diffuse involvement at presentation. Another manifestation of synovial disease is the production of mineralization within the synovial process and the so-called synovial chondromatosis or osteochondromatosis if it ossifies. This is the presence of a large number of these areas of osteochondromatosis posteriorly in the knee joint. And what is important perhaps to highlight in this patient is the fact that the loose bodies don't give rise to the same MR signal. This is a T1 signal that shows a lot of marrow bone within one of these loose bodies here, and also posteriorly, inferiorly at this level, whereas virtually all the others have very low signal due to dense bone forming the loose body. And the same features are replicated on CT, showing you the dense loose bodies full of bone, as opposed to this area here and here, which is a thin rim with a lot of marrow containing bone superiorly and inferiorly. Infection also presents with an effusion, and this effusion can be a sign of septic arthritis, or it can be sympathetic in reaction to an infection within bone. You can see the hallmarks of infection with a lucency destroying bone and the surrounding edema of the marrow. This is a T1, and kindly note that there's also a rim which separates the area of bone destruction from the edema zone, which is seen on both axial and sagittal sequences. One can identify the synovitis both in the axial plane by the enhancement of the periphery of the synovium, as opposed to the fluid component seen on the sagittal plane as well, and kindly note that there is no enhancement in the area of bone destruction. This is fairly typical, this layered appearance forming the so-called penumbra sign, separating the necrotic area from the edematous bone that is viable adjacent to it. Loose bodies can grow. They don't really tell you whether they originate de novo from the synovium or from the osteocartilaginous outline. In this patient, you can see multiple loose bodies posteriorly in both knee joints. But what you also should appreciate is the abnormal marrow pattern of bone here and also in the tibia within the metaphysis. And this is osteonecrosis. And when osteonecrosis develops, it renders the bone weak, including the weight-bearing aspects of the condyles, and one can have fractures with the formation of loose bodies. The hallmarks are a sclerotic rim above and below the knee joint, usually coming close to the subchondral bone but not involving it unless it fractures. And the MR is fairly typical, showing this double track sign that is so typical in all areas which are involved by medullary osteonecrosis. Joint space loss is also a sign of disease, and it's very important that if you are wanting to assess the joint space, you do this using weight-bearing films. This is a radiograph of a knee in the AP projection compared with a coronal MR a few days later. This is done weight-bearing. This is done with the patient supine. Kindly note that on weight-bearing, the lateral joint space is normal, whereas the medial joint space is severely involved with almost bone-on-bone contact. And you can see how important the weight-bearing film is in showing you this abnormality, because when you are supine, the joint space opens, and it suggests spuriously that the joint space is fairly good, as it is laterally. But if you look closely, there is fluid here, and there's no cartilage at all in the joint space itself. This is all osteoarthritic compared with the lateral compartment. Joint space loss can be focal, or it can be multifocal, meaning you can involve all the three compartments of the knee joint. Osteochondritis dissecans is a condition that involves usually adolescents or early adults. Kindly remember that the lesion can heal spontaneously, particularly if you pick it up early and appropriate treatment is instituted, but it can also give rise to loose bodies due to bony and osteocartilaginous fragmentation from its crater. The objective is to detect it, showing it in the dissecting plane, and also to assess the overlying cartilage, as this is a very important prognostic factor, as well as the marrow pattern within the component of the bone, either parent or offspring, in relation to the osteochondritis dissecans. A condition called subchondral insufficiency fracture has replaced the condition previously known as spontaneous osteonecrosis of the knee. This is a condition that occurs predominantly in the elderly and predominantly in females. And more often than not, there is no history of trauma, but there is poverty of bone within the knee, particularly in the condyles. When you assess the plain film radiographs of patients complaining of knee pain in this age group, kindly look for the early signs, subtle signs, like a double sclerotic line close to the subchondral bone outline, and the impression that one sees in the outline when you assess the condyle in the weight-bearing portion of the lateral radiograph. When you see those radiological signs, you need to know that on MR, what you are seeing here is a fracture which goes across the subchondral bone, hence the cleft, which is fluid-filled, and the fracture that you saw on the plain film is associated with a large amount of edema within the condyle where the fracture has taken place, and there's the compression that you saw on the radiograph as well. The fracture needs to be differentiated from a bone bruise, where the cortical and subchondral bone outline remain intact, whereas the trabeculae are damaged and the intertrabecular space becomes edematous with hemorrhage as well within it. Kindly note the difference between the bone bruise and the subchondral fracture once again, where you clearly have a fracture line which is quite nicely seen separate from the edema within the marrow space. Causes of knee pain, particularly in the growing skeleton, can arise from the quadriceps mechanism and the insertion, particularly to the patella, and the tibial tuberosity. Now, these tug lesions can affect the superior pole, the inferior pole of the patella, and also the tibial apophysis, and the signs here are soft tissue swelling of the ligament or tendon and bone changes, which are usually reactive, but it can also show signs of avulsion of part of the apophysis. Once you note that you've got soft tissue thickening, then you must assess the adjacent bone, and if you do so, there are ossicles seen here, and you'll notice that the gap between the tibial apophysis and the tibia is widened, indicating a chronic stress process producing thickened ligaments, ossicles, sclerosis of the beak of the tibial apophysis, and separation, which is a chronic process from the parent bone, all producing pain and morphological changes. Another form of tug lesion occurs particularly in the young in the so-called periosteal sleeve avulsion of the patella. This can be easily missed if the radiograph is done too early, because the signs that one sees in the inferior pole are purely reactive, and although one still refers to it as periosteal sleeve avulsion, it's probably not accurate to do so, as there's no periosteum in a sesamoid bone. But nevertheless, one can understand the mechanism here, which is the avulsion by the patellar tendon or ligament of the attachment of the inferior pole, which produces edema, separation, and the fracture line here, and then with healing one can see new bone formation on the radiograph. Inflammatory processes can also affect the quadriceps mechanism at the sites of attachments of ligaments and tendons, at the special developed site called the enthesis. And when this happens, the enthesis inflammation can involve the superior, the inferior pole of the patella, and it can also extend all the way down to the tibial apophysis. And it can involve all three, as in this case. You have an inflammatory process extending all the way, even on the superficial surface of the patella, from the quadriceps extension attachment to the tibial apophysis, with considerable pre-patellar and infrapatellar soft tissue edema. And here is the appearance showing you this enthesitis with a reactive change, some new bone formation, and the soft tissue swelling in the pre-patellar space. A common cause of injury is meniscal injury in the form of a tear, and the tear can also sometimes be associated with a cyst. And a quick refresh as to what structures normally look like. The menisci should be sharp, they should exhibit low T1 and low T2 signal characteristics on all sequences, as opposed to the hyaline cartilage and the subchondral bone interface here, which is nicely seen in the coronal and the sagittal planes, as well as the axial plane of the patella. To diagnose a meniscal tear, therefore, you need signal change and also morphological change. And if you compare in this coronal image the lateral meniscus from the medial meniscus, you've got signal alteration, truncation, and also separation of a fragment extending towards the intercondylar notch, close to the attachment of the posterior cruciate ligament. Cysts are more common to feel clinically in the lateral aspect because you've got very little soft tissue overlying them, but they do occur equally commonly in the medial aspect in relation to a medial meniscal tear. And what you're after here is the demonstration of fluid characteristics, low T1, high T2, and adjacent to a medial meniscus, usually a horizontal tear, which you can see almost invariably communicating with the meniscal cyst. Anterior cruciate ligament, particularly in sportsmen, are very common, and one needs to differentiate radiologically from a tear of the substance or its origin or insertion from an avulsion of bone, which usually occurs in the growing skeleton. The signs are morphological signs of an undulating appearance. There's pseudo hypertrophy due to swelling, and also an abnormal orientation of the ligament once it becomes detached, for example in this case. Not uncommonly, ACL tears are also associated with further tears, in this case a tear of the medial collateral ligament. ACL avulsion is also an important diagnosis to make. This is easily overlooked by both plain films and also MR if you're not careful. One can see a continuous ACL until you look at the marrow pattern on the edema sensitive sequence. You will not detect that there is in fact a fracture and an avulsion of the footprint of the ACL into the tibia and the tibial spine. Similarly, posterior cruciate ligaments can tear or avulse from their attachment to bone. This is a condition that is increasingly being seen in the elderly osteoporotic ladies who take up athletic pursuits, and one can identify lots of soft tissue trauma, but there is the clue that there is an avulsion fracture here with an intact PCL attachment to the posterior aspect of the tibia with a fracture line clearly visible. And if you want to make double sure that is what you're dealing with, CT is very useful in identifying the fracture cleft and also in identifying how much retraction has taken place, as it may affect therapeutic options. Medial collateral tears are fairly easy to diagnose on the coronal MR, showing fusiform swelling, sometimes associated with an element of avulsion, giving rise to adjacent bone marrow edema on either the coronal or the axial plane. There are three types. Type 1 has edema on either side of the ligament, superficially and its deep aspect. Type 2 has a disruption, but only part of the thickness of the ligament. This is probably the most common type of injury, whereas in type 3 you have complete thickness there, which ends up with an undulating pattern once you have separation of the fragments of the two components of the MCL. A very important sign of an injury, intra-articular injury, is the Segon fracture, and kindly note that this is a small fragment of bone due to avulsion of soft tissue attachments to the condyle of the tibia. It is not an osteochondral injury, nor is it an injury from the fibula head. Usually it is due to avulsion at the iliotibial tract or one of the oblique attachments of the lateral collateral ligament to the tibia. When you identify these Segon fractures, they're not uncommonly associated with the tears of the ACL and other injuries intra-articularly. But once again, please note they're easily missed on MR without the plain film to show you the avulsed portion attached to the soft tissues attached to them. The last part of the talk will address some problems with imaging of the patella, and we start off with the dorsal defect of the patella, which is not an osteochondritis dissecans. This is probably the reason why I've included this. It almost invariably occurs in the superolateral portion of the patella, in the same site where one would expect to see a bipartite patella. So one looks at this AP view, which is a reformatted image by CT. This is medial, this is lateral, and this is superior and inferior. One can see the defect here in exactly the same location where one would expect to see a bipartite patella. On a radiograph, one appreciates a lucency, and on the axial plane, it is really most likely an incomplete ossification problem that gives rise to this defect. The articular cartilage needs to be assessed and is found to be completely normal and continuous above this subchondral bone abnormality. Bipartite patellae are common, and only about 2% of the people with this abnormality have symptoms, particularly sportsmen, of course, and the symptoms can be due to a problem in terms of a stress-related phenomenon on the bipartite component. You can have problems at the junction in the synchondrosis between the fragment and the parent component of the patella, but more often than not it is problems at the attachment of the rectus femoris tendon, which is of course under different tensions that produces the symptoms. Patellofemoral OA can be isolated, and if it is, you need to remember of a condition called calcium pyrophosphate dihydrate deposition disease, which has an affinity for evolving this joint, or as usual, it is more common to see it as a sign of arthritis at multiple parts of the weight-bearing joints. And the last condition I'd like to stress is the transient patellar dislocation. And the importance of this is that when the patient presents to the accident emergency unit, more often than not, the patella has relocated into the trochlear groove. So although it's a lateral patellar dislocation, which is complete, at the time the doctors assess the patient, it's transient, meaning it's gone back in place. So it's very difficult. These are very difficult to diagnose. There is tenderness, of course, laterally, and because the patella has relocated, there's also tenderness medially, not only of the bony injury, but also of the areas that can be injured to the medial supporting structures of the patella, namely the retinaculum and the patellofemoral ligament, with, of course, an effusion. So what are the signs? The signs here are, as I said, a patella that's relocated, hence the word transient. You have a bone bruise in the lateral condyle, which is in this case, but not invariably so, associated with a fracture, an impaction fracture. And the edema on the patella, however, is seen inferiorly and medially. So large bone bruise in the condyle, laterally and inframedial bone bruise in the patella. We now move to the tutorial cases. And I have two cases for you. The first case involves a patient who had a skiing injury and was immediately unable to walk. I'm going to show you some MR sequences in the coronal, sagittal and axial plane, and I'd like you to tell me what you think the diagnosis is. Sagittal sequences, coronal sequences, and an axial sequence. And to help you in your assessment in a structured way, I'm going to ask you to look specifically at answering whether there is a tear of the ACL, or possibly a tear of the PCL, or possibly a tear of the MCL, or what about the lateral collateral ligament, or is there a tear of the attachment of the biceps femoris tendon? What do you think? If you analyze these sequences, the answer to those questions is they're all been damaged. The ACL has been damaged, the PCL has been damaged, the MCL has been damaged, the LCL has also been damaged, and there's no biceps femoris attachment at the normal confluence with the lateral collateral ligament. And the point of this exercise is that although structured approach is very useful, you then, however, need to cerebrate. By that I mean you need to make a conclusion as to what this means. And obviously, if virtually all the ligaments of the knee have been disrupted, it indicates that they've more likely been disrupted simultaneously, and for that to happen, it is more likely that it happened at a time when the knee had undergone a complete total dislocation. So when we image patients, we tend to image them in as comfortable a position as possible after we've relocated the components of the knee in a quasi-anatomical plane. And you cannot identify any hint of dislocation, possibly some element of incongruency here, but it's by us cerebrating from what we see that we conclude that for all these ligaments to have been ruptured, in all probability the knee must have dislocated. And in fact, if you compare the MR with the plain films, you can easily see why this lack of congruency and shift here would be indicative on the plain film as a total dislocation, whereas on MR it's not that easy unless we specifically think of it. The post-operative features showing ligamentous reconstructions here with the Pellegrini-Stierda response seen on the post-operative radiographs. The second and last case is a young cricketer who was batting and on hitting a ball turned round to make his run, rotated his leg, twisted his knee and collapsed. He had immediate pain and swelling of his knee, taken to hospital, and this is the MR, of which I'm going to show you some images, and I'd like you to suggest a diagnosis. So you've got two coronal images and another coronal images here, two other coronal images here, two sagittal images. These are all proton density fat set images, and 6 axial images through the patellofemoral joint. And while you're looking at this sequence of images, I have some questions for you. Firstly, do you think the ACL is torn? Do you think there's a tear of the meniscus? Could this be infection? Or could it be dislocation of the patella? or would you entertain a diagnosis of osteonecrosis? Here are the images again, and one can see the patient has an effusion, some bone bruising laterally, and some bone bruising inframedially in the patella, with a contour abnormality of the lateral femoral condyle as well. And the diagnosis is, of course, an acute patellar dislocation. But what I'm not sure is whether you picked up that there was also an osteochondral fragment indicating the presence of a fracture. In every patient where you entertain the diagnosis of a transient acute patellar dislocation, you need to look carefully to see whether there is or there are within the effusion fragments of bone or fragments of cartilage. And if I make an emphasis on the few images in a larger format, you can see that outlined by fluid laterally is an articular cartilage surface with the subchondral bone beneath it and some of the bone beneath that. And this is lying laterally here, and is a direct consequence of the patellar fracture that involved the lateral femoral condyle. So it's important always in a transient dislocation, in the same way that you would do it after a shoulder dislocation, to look for loose bodies. You need to look for loose bodies in an acute patellar dislocation. Thank you very much for your attention.